My name is Dr. Lasker. I'm a consultant radiologist, and welcome to Radiology Seminars. I'm doing this talk on behalf of Radiology Seminars, one of the companies that I run, very much based on the idea I like to teach, and I like to teach on my own platform as well. So for those that have come and given up some of your evening, I really do appreciate that you've given me your time. We've got quite a lot of people here today. Hopefully you can see my screen, but what I'm going to do is open up the chat, and there should also be a Q&A area. So I've opened that up as well. So if there are any questions during this talk, then please do feel free to throw me a question or anything like that. And my team will also be able to help during this as well. So yeah, hopefully you can see my screen. Just get my phone out so I can tell if the team are trying to contact me. Okay, good. So we're going to be talking today about the lumbar spine fellowship that the Radiologist Seminars runs, right? And for those that don't know what a fellowship is, it's a chance for anyone to either upskill themselves in lumbar spine MRI scans, or it's someone to learn about how to do MRI scans in the first place of the lumbar spine. And this can be very, very important for those that work in any sort of DGH, and for those that don't know, a district general hospital. Those are kind of guys like me who work out in the sticks, as it were. We end up having to do lumbar spine MRIs a lot anyway, whether we are MSK or not. Also, in the private sector, a lot of people have back pain. So MRI scan, lumbar spine imaging can be really, really important when it comes to reporting. It can become a really, really big part of your reporting. And it can be fraught with a whole load of danger because it doesn't feel like it's going to be difficult. But when you actually start delving into what it entails, what structures you're looking at, it can start to get a little bit stressful. And so, just to introduce myself again. So, my name is Dr. Lasker. I'm a consultant radiologist, fellowship trained in MSK and trauma imaging at Imperial. Currently a consultant at Basildon and Thurrock Hospital, and I've popped up in various places because I like to teach, and I like to try and make things as easy as possible for people who also want to learn as much as possible from myself and my colleagues and our faculty. And over the years, we've managed to build quite an impressive faculty. So, I'll be very open and honest. My training was very, very hard. For those that have kept up with any of my social media and stuff, I've been very open that I found it very difficult. I found that getting the volume of knowledge was very, very hard. I think it takes a kind of a different kind of personality who's able to ask lots of questions when you're not entirely sure about what's going on. And I definitely found it a little bit hard to try and yeah, make sure I was asking the right questions. And now looking back, I wish I asked more questions during my training. I really did. And because those are the times you can ask. And once you become a consultant, once you start working in a place, then you get this question like, oh, how comes you don't know this? And that can be a little bit of a hard question to let alone answer, let alone take, because it can make you feel quite small, actually. And so I found that being registrar was quite difficult, depending on the number of cases that came in during the day. Yeah, you might get some good cases, you may learn from them, you may not. Also, I was probably a little bit lazy. I went for the easy cases a lot of the time, and not all my trainers are good. Unfortunately, some of them weren't that interested in training, and that's just the way it is. They've got their own thing, they've got their own stuff going on, but you yeah, you just end up having to try and find the people that you kind of vibe with and go to them and learn from them. And the amount of knowledge there is when it comes to learning how to just report anything really can be quite vast. And that's why we are subspecialized on a lot of levels, and almost on some levels, maybe too subspecialized, because we have to get to the point where we are comfortable being able to report quite a lot about, oh, has my screen stopped sharing? I feel like something just happened there. So there's quite a lot to get through, and that can be really, really daunting. And the other thing is that it's about finding people that you vibe with. How do you find people that are kind of like-minded, that kind of understand where you're coming from, and are not going to judge you and genuinely want you to learn? And as the years have gone on, or as the years went on, I found finding people like that on that level quite difficult, actually. And so there's a question that can come up, like, "Oh, I thought you would have known this at your stage." And that's a really hard and harsh question to ask, and a hard one to answer, because after a while you feel a bit like an imposter. And maybe that's the reason why people ask me that question, like, "Oh, how come you don't know that?" Maybe they're trying to make you feel uneasy. And so what we're trying to do is create an environment where we're able to have those conversations, have that kind of learning, get that kind of teaching. We can genuinely ask any questions that you want. Now, I found that over the years, I've been added to loads of groups, and a lot of them are going to be MSK. Like, I literally typed in MSK, and you can see MSK troubleshooting, MSK teaching, MSK this, MSK that. I've got loads of groups. And again, they were quite useful, especially in the beginning, because I kind of knew a lot of the people in there. And as it got bigger, I didn't know everyone in there, and I started to not really um, not really know who's in there. And then I started feeling a little bit embarrassed about asking questions and what they think of me if I ask a particular kind of question. And again, I mean, I thought you would have known this at your stage. That's the question that would keep coming up, and I'd feel kind of, oh, maybe I don't want to be talking to these guys. And I stopped talking as much as I used to. And this is a wonderful person that unfortunately passed away. And for those of you who don't know, that Dr. Asif Safdin was awesome. He was someone I got to know. He mentored me a lot and taught me a lot of things over the years, not just about radiology, actually, a lot about life and being a consultant and the kind of consultant I wanted to be. But he was really good. You could ask him whatever you want. And to the point that I remember, I still feel bad about it on some level. He was very, very unwell and he was getting treatment for his illness. And one day someone asked me a question and I didn't know the answer. So I called him and he picked up. And then I said, "Are you busy?" He goes, "Yeah, I'm in the middle of getting my treatment." And I thought, okay, you know what? You don't need to answer this question. He goes, "No, no, no, I want to answer your question." And I found that so wonderful that there was someone out there that was just always up for answering a question, always there, and never really seemed to judge me when it came to my, quotation mark silly questions, right? And so post training or even pre CCT, teaching can be very, very variable. It depends on what comes in and depends on what kind of trainers that we've got. So I started to think to myself, like, okay, I had these difficulties. How can I make this better for other people? How can I give them an area where they can turn up to and they can genuinely learn, not be scared about what they do or don't know, and genuinely be able to sort of get better at radiology and different aspects of radiology. So we've got MRI spine, which is what we're talking about today. We've also got MRI, the knee fellowship. We've got a neuro fellowship that we're running. Hopefully, going to be moving on to other things as well, where someone can turn up and go from knowing absolutely nothing and go all the way through to be able to learn loads and loads and loads and become really, really competent and hopefully be able to teach other people as well. And so I thought to myself, well, you know what? I've been doing this teaching thing for a while. I managed to get a good bank of people that I know really well. I do trust them. I know they're knowledgeable. I know they're non-judgmental because I talk to them a lot. And they're all very positive. They're not negative mindset. They want you to become better. You want you to perform. They want you to do the best scans you can. And then I thought, well, why don't I create something? Why don't we create something where we could all learn together and learn from interesting cases, learn from what's coming up? And so what I had was this unfair advantage. Yeah, I had Dr. Safdin when he was alive, but I have other people through Dr. Safdin, other people who are highly trained that I've got access to that I can just message and say, oh, by the way, what do you think of this? And so then we decided to bring everything together to be a really focused training scheme, right? And this would mean that you could turn up and you could stay with us for 16 weeks and beyond, actually. And what we found is that when people came to our fellowships, when they came to our teaching, they'd WhatsApp us, they'd create new WhatsApp groups, or they would email us and say, oh, by the way, I had this case come in. And that's the thing, when you do go to other courses, and believe me, I have, and that's why we created our own forum, is because they make you think that you know a lot by giving you lots of easy cases. But actually, you want the cases where you will genuinely learn. Someone's asking about a certificate, sir. A certificate you'll get at the end of this. I think you'll get it by email. If you're talking about a certificate of the fellowship, you'd have to go to the fellowship for that. Anyway, so we decided to do a combination of things. So we look back and we realize, okay, most of the time that when we learn from each other. We learn from being in school. We learn from being in nursery. We learn from being in secondary school. We learn from being in university. And then when you start learning, you actually learn together in a community. You learn together on the wards. So most of the time, you will notice that you do learn better together. And genuinely, when you have people around you that are willing to help and help you learn, then actually that's very, very beneficial. And so we created a mentorship where you can be able to work through cases, where you'll be able to work through our teaching materials and also have genuine mentorship where you can genuinely ask whatever you want. I think the other day we had a conversation, and it's genuine conversation where I put a scan up and I was pointing at one of the ankle ligaments, and at the time I thought it was definitely the posterior tibial tendon that was a problem. And then we had a discussion about why it's not the posterior tibial tendon; it could be the peroneus brevis, and that went on for a while, and it was fine. I mean, I know some people say, "Oh, that's just basic anatomy. How come you don't know that?" But the point of the forum is that you can ask that, and we had a good discussion. We put the diagrams up and show that this has to be this particular anatomy because of this, and then it was actually quite fun, and we still talk about it now. And so it's nice to have a team. It's nice to have people around you, where you actually genuinely want to help each other on work and learn together. And so this is just a quick. I'm going to go through some actual cases soon where we actually get some information and stuff. But this is what it looks like, right? So you've got your spine fellowship, your knee fellowship, and you've got a whole load of stuff where you can introduce yourself, you can talk to each other. And even to this day, I haven't done one. I was going to do one today, but anyway, even to this day, I'm still putting up cases and genuinely asking, like, I don't actually know what's going on here, guys. Like, can anyone give me any answers? And we've got some really highly qualified people in there who give their genuine answers and stuff like that. And you can see how it works. And exactly like, oh, for those that are old enough to know what Facebook was like, Right now, I don't know what you guys think of Facebook, but I turn up and there's just loads of stuff being thrown at me. I don't even know what it's about. But this is more of a curated Facebook for very geeky people who genuinely want to learn and want to learn about MSK. And you got your case help SOS where you really do need some help and you need it soon. You got your 1 day turnaround, 2 day turnarounds, and this is all teaching, right? This is not. I'm not going to go. We're not asking people to re-report things for one another. We're not saying we're a reporting forum. We're saying a teaching forum. So everything's anonymized. We have people on there who log in regularly to make sure everything's anonymized. We only had one occasion when something was shared and we thought it was a patient details and we had to get rid of it, contact the person, and it turned out it wasn't patient details, it was their own details. It was actually their login name and stuff that was on there. So disaster averted. But we know people who are on there, we know we can vouch for them and we know who each other are. So it means that we can actually call them up and say, look, what's going on there? Why you put that up there and stuff like that. And thankfully nothing like that's happened. And we do keep it very, very tight knit. And so this is what it looks like. So this is me saying like, hey, what is this? What's going on? Is it a pseudotumor? When do you call it a pseudotumor? And then, within a 24 hours, we get people, another person asking about certificate. Look, it should be there. You will get a certificate at the end of this. And if you want to get a certificate from the fellowship, then you come to the fellowship. Um, so this is what it looks like. I'll put a quick few questions. I've got my colleague here saying what's up here, and we put like teaching case and stuff like that up there as well. And we've got interesting talks that have come up over the years that can be genuinely useful for people. So Ram, he's one of the consultants at RNOH who's done a really brilliant talk on tumor mimics and bone marrow. And I don't know about you, but I even find that difficult to this day to really know what to do in that situation. That talk is absolutely brilliant. It goes through exactly how you deal with any sort of bone marrow abnormalities at all in any sort of situation. And you can see that we kind of talk to each other, we comment, we like, you can highlight things, you can bookmark things, you can, I think, to the point that even if you now, because we've got such a massive bank of cases and stuff and discussion in there, you can type in the word stress. Maybe you're stressed out about something, type in the word stress, and straight away you'll get a whole load of stuff to do with all the stress fractures that we've talked about, all the things, all the data that's to do with that, the papers that have associated with stress fractures and all things like that. So it's really, really good. And we also make it so that it's a teaching forum. So if there's a really interesting case, then I mean, it's anonymized. You can just pick off that image, download the images, nothing blocking you from using the data there to be able to use for your own cases and your own teaching. And there's a prof on here that's asked me for cases a few times, and we've been able to exchange it on the forum so that they can make their forum better. And this is how it goes. You kind of type in what you've got, and you can do this on your phone. So this is actually what it looks like on your phone, uh, where you're seeing something. Oh, I don't know what that is, and then you kind of have a look, and then you just say, have a look, and say, okay, I don't know what's going on here. And then also, one of my colleagues will answer that next question in just a minute when it starts. The Lumbar Spine Fellowship, and you put the photo, ask your question. You can even do a little poll, you can do a little video, you can do hashtags, whatever you want, and it's really fun. And sometimes I put on little things about what part of anatomy is this, or what do you think this is, and people come out with all their answers and stuff like that, and have proper little votes and geeky discussions. It's really nice. And so we have like a mini, and actually weekly, we've started to do sort of more regular meetups, but during the fellowship is when we really focus on the fellowship people. We have weekly meetups, 16 for 16 weeks, where we go through the cases, any cases that people have brought in, and we actually get sort of guest speakers to come in and talk about specific parts that they're particularly good at. So if someone's particularly good at trauma, we'll bring them in during the sessions. Everything's recorded as well. So if you can't make it to a particular talk, then you can just come and watch the recording later and that kind of thing. And also, we try and work with you. So there have been occasions where it turns out actually everyone's free in the middle of the day rather than the evening. So we kind of switch things to try and cater for the most people. And again, we're always accessible, especially during the 16-week period when we're all working together to try and get you through 16 weeks of material. We're happy to try and pitch in and try and help you out to try and get through the material as much as possible. So it's a bit of an MSK club, a bit like a Fight Club, except you are allowed to talk about it because I would like more people who are like-minded to be part of it. That'd be lovely. And then we also have these weekly case downs and rundowns. Now, something that's very exciting, and I'm glad that if anyone's stuck around, I really want you guys to see something that we've been working on. And so the fellowship concept is a relatively newish concept in the world of online teaching and online media, I guess, when it comes to learning. So we've had webinars and all that stuff for many years, but the community thing is something that is relatively new, and we were one of the first people to bring this up to the market. We brought it in, and we've actually had massive, massive success up and down the country and around the world with people turning up and being part of our communities. But we've decided to try and take it a little bit further and try and create something brand new based on what is out there. And I'm going to say the dirty word in just a second. It's called AI. And I know everyone's been, oh no, not AI. AI is going to take over our jobs. And yeah, it might do. I don't know. But what we found is that when people were working through our community cases, they would have very specific questions, and sometimes they couldn't come to the lesson, or they couldn't quite come to the thing, or they couldn't quite understand. And so what we did was create this thing called PaxBeam, where essentially you could go through a case that's been talked about in the course, and you can interact with the case and learn from it. So, for example, I'll do it now, right? So I'm going to pretend to be someone who's learning. This is a fully packed viewer, so let's go for this particular image here. We might as well make this a teaching session and go through it together. So my internet is very slow here, so it might take a few seconds. Okay, so let's say we have a look at this one, for example. And so for those that don't know, that's the sagittal T2 weighted images. This is the axial T2 weighted images. And you can see on the sagittal views anyway, there's a bulge here, a bit of a bulge here, a bit of a bulge here, a bit of a bulge here. Right, these are the intervertebral discs. And you can see that this looks slightly bright, that looks a bit darker, that looks a bit darker, and that looks slightly dark as well, which means that the fluid is now not there anymore. It's dehydrating as time goes on. And that happens to a lot of us as we get older. We start to lose a little bit of height because we don't have as much fluid within the nucleus pulposus, the jelly-like material anymore. But now as you scroll down, what you'll notice that this is the spinal canal, and there's all these tiny dots sitting right in here, all the little tiny dots, right? And these are your nerves. And they kind of come down from your conus like a horsetail, goes all the way down. And as you scroll through the sagittal views, you can see that some of them are going down and some of them coming out through the exiting nerve foramina. And if you look at this area over here, you can see that this looks like a little bit of a fisheye with a bit of fat around the outside. The teaching, I mean, I will go into more detail during the actual teaching sessions, but you can see that that's a bulge. And as you come further down, this one's kind of got this linear line going through it, like a line going straight through. That looks like an annular tear. And again, we're going to talk about that more properly in the rest of the talk. Now we come up to in the rest of the fellowship, but here, when you come here, you can see this disc bulge is coming far more outwards, right? And actually, those little lines that we saw earlier, they look a bit squashed, they look a bit kind of impinged, as it were. There's a bit of spinal canal stenosis as well. Coming onto the outside areas over here, the lateral X aspects, you can see there's still a bit of a fisheye here, so not quite impinged on the exiting nerves. And you come down to here again and again. And down to here, you can see that actually there's a bit of a bulge here causing impingement of the left descending nerve. There's a nerve here, but not much of a nerve here. But why am I showing this? What is the most amazing thing that we managed to build is that we can talk to the tutor and learn from it right here and then. So I think there is a large disc bulge at the level of L4/L5. And you type that in, gives a couple of seconds. There you go. There you go. Good observation. You're right on the focus. To help us further characterize what you're seeing, can you describe the disc bulge in more detail? What specifically makes you say it's large, and what structure does it appear to be interacting with? Let's say, okay. So then you can say, I think it is impinging the descending nerves. And what did it ask again? What more detail? And the bulge is wide at the base. You click on that, and then you say, okay, you've hit some key points. Let's break those down. Impinging, which nerves are and you see what I mean? It properly interacts with you so you actually learn. You start to understand that, okay, this is how to go through the scan. This is what to understand. And what the learning things is trying to get to me is a bulge is wide at the base. There's a great descriptive phase. When this is wide at the base and extends circumferential, what does that tell you about the potential for spinal stenosis and nerve and stenosis? Okay. Okay, so number one, I would say it would be descending nerves at L4/L5. And what they say about the bulge, wide at the base, bulge would be causing moderate spinal stenosis. And you kind of look at that, and it's getting you through. It's getting you to understand, like, okay, this is what you're finding, this is what you're understanding. And this is absolutely crazy. And I've been playing around with it. I've been actually learning. It reminded me of some of the cases that we're going through as I was building it. And this works. And we've got so many cases. And I think what we're going to do is and we have incorporated this into the new fellowship that's coming up, where you can literally work through all these cases. Like there's 21 cases there, 20 there, 14, 20, 20, 11. There's a lot of cases. I think there's about 300 cases to work through, where you can talk to the tutor, understand what's going on. And if you really want to just get the answer, you can go get the notes if you really want to. And actually, I think you can take notes as well. Yeah, you can take notes and save your notes here once you're logged in. So someone's got a question. They're just saying hello. Hi back to you as well. Hope you're well. So this is what's so amazing, and I think I'm very proud to stand with radiology seminars as we go into sort of a new era of teaching where we are now talking about enhancing. So a lot of people are worried about AI, like what could it do? How could it take away our jobs and stuff like that? But actually, we're talking about enhancing AI to increase our learning opportunities, right? So you could be in a different time zone somewhere else completely, and you may have missed the session, and you think, you know what, I'm going to work through the case and then go watch the video, or watch the video and then see this, and then look at the ideal report that this would be and things like that. So really, really exciting and something that we brought to the market. And we'll be bringing that to the Neuroradiology Fellowship and Knee Fellowship very soon. But it's a lumbar spine people that will get that from the outset. They're going to be the special ones who are going to be able to take advantage of that. So the whole point is, what's the point? Why are we doing this? Why are we trying to create this? Why am I going through the hassle of creating this stuff? Ultimately, as a company, as a person, I believe that if I help you help someone, I've helped that person as well. And the more people you help, the more people I help too. I think this is how the world works. And so far, it's worked very well for me. And I think that this is the way I want to be. And using the tools that we have in this day and age, I think we can help even more people. So through you, you can help more people. You could introduce people to us and we can help them. And especially the new AI thing, where actually your time is used to the maximum of your ability, then you could be able to increase your efficiency for learning, be more productive with your learning if you want to, and genuinely increase your knowledge where someone's asking you the questions and trying to get you to really think about what it is. And you don't have to be embarrassed. You don't have to be worried. Like you can ask the AI whatever you want. You could say, what pizza should I order? And it'll probably answer you. I haven't tried that. I might try that later. But you could ask, what kind of pizza should I order today? And it'll be able to tell you. And this is useful because lumbar spine, like I said, is a massively integral part of any sort of radiology job, really, because working at DGH is going to turn up when you're hot reporting, you're doing on calls, and then you will be able to, something like this will turn up. You know, oh, you know what, like I'm going to have to report this. Could it be called a quina trauma scan that's coming in? They want an MRI scan. Is that the right thing to do in this particular situation? These are things that are going to come up, and that's why MRI lumbar spine is the first thing we made, the first thing that we've introduced as AR model too, because I think this is going to be the thing that's going to help people a lot. Someone's asked a question: as a radiology technology, what should our approach be to do the best MRI scan and maintain the proper parameters and get optimal image quality? I wish I could tell you that because I'm not a radiology technologist. I'm a radiologist, so I report the scans but don't take the scans. But again, these are the questions that we can answer. We do have radiographers who work with us very, very closely, and if you've got a question like that, then we can definitely answer those questions. But I'm not going to pretend to even know how to go about doing that. But with us, you do get this genuine mentorship as well. I mean, we genuinely are very passionate. I mean, the amount of time and effort that goes into creating this, you'd be thinking like, you're mad. Like, why are you be spending so much time? Surely you should be doing something else with time, like spending time with your kids. But I genuinely enjoy this. What qualifies for cord equina? So cord equina is where you get sort of compression of the. Remember I was showing you that scan earlier? Let's go back. So if we open this one, and you get complete loss. Like it's really, really bad. And in fact, let me say, is this Corda Equina? Let's have a look. Right, it's going to start bringing you through that. But okay, fine. So the point is, like, when it gets really crushed up like that, that's when you start thinking about Corda Equina, when you don't really see much of the little gaps between the individual nerve roots at all. Then you're going to start going down that road. But someone like this who's got this kind of thing, if they turned up on call, you'd say that yes, significant stenosis that's causing their problems. Right. So, someone's messaged me. Right. So obviously, if you've got any questions, then please do feel free to ask about what we're offering here. But I know you guys have spent a bit of time with me now. So if you guys are up for it and do want to join, then for a short time period, we are offering 20% off. So if you go to the link that my colleague will be sharing in just a few minutes, then you should be able to click on that, click on the link, and then you should be able to get 20% off. And I genuinely, there's no greater investment than investing in yourself. So if you are someone that wants to learn how to properly report, then this is a really good way to do it. By the way, I should have mentioned that Dr. Asif Safdin, he contributed pretty much most, if not all, the cases on this. He actually has some recordings of lectures. For those that do know him, you'll know how special he is or was. And he did recordings for us, and we donate charity. We donate money to charity because that's what he wished for any of his teaching materials going forward. So if you are interested, please do come along and support his work essentially as well. So yeah, type that in and get yourself logged on and get going on our AI AI teaching bot and also get interacting with us and get to learn as much as possible. So any questions? I'm just going to check my phone, see if any questions are coming up here. Okay, no questions there. You're going to check the other thing here, Q&A, 3 questions, I think. Where are they? All right, yeah, I could do that. Someone's asked me what important sequences do I use during analysis, during a report? Okay, so the workhorse for any sort of imaging, for me anyway, is going to be the T2 weighted images. For those that don't know, T2 weighted images are where fluid is bright, H2O is bright, so T2 weighted images are bright. So this is T2. Fat is also bright, right? So now when you go to T1 weighted images, the fluid is dark, but the fat is still bright. So you can see if I compare T1 with T2, you can see that the fluid is gone, but the fat is still there. So when we go to the exiting nerve foramen we were talking about earlier, which is this area over here, it's a little fisheye and a bit of fat around it. But I know that's fat, but it could be fluid. Could it be fluid? I guess it could be because fluid is bright too. So what we do, we go across to here, and actually now you can see that there is a significant amount of fat around there because it's bright on both. So anything that's bright on both is going to be fat. Anything that's dark on T1 is going to be fluid. Now, generally speaking, I do have a cursory look over this if I'm concerned about whether something's fat, whether something's not fat. But generally speaking, it's going to be the T2 weighted images that are going to be the most useful for any sort of image interpretation. Reason is because you can see annular tears and you can also see the individual nerve fibers really, really well. When you go to the T1 weighted image, it's a little bit harder. I mean, you can see them, but not as easy as this. Can you see how easy it is there compared to here? Definitely, you can see the dots that are making the nerve fibers a lot easier. But as you scroll through, you can start to see where these little nerves are going and then whether the bulge is touching it or impinging. So this here, you can see a gap. There's not much of a gap. So you can say, oh, there could be a bit of irritation down there. Might be if they've got symptoms. Coming further down, there's a gap there, a bit of fluid between there, but not so much there. So therefore, that's going to be slightly irritated, maybe slightly impinged. But this is where it really gets a bit pushed out, really, really significantly compressed. Yeah, I mean, you'd be saying that this is significant spinal canal stenosis with significant narrowing of the lateral recesses. So it really is the sagittal T2s and the axial T2s that give me the most information when I scroll through. But then the final thing that really kind of helps as well is going through the fat saturated images. Now, the fat saturated images are images where the fluid is bright, but the fat is now dark. And we've done it artificially because if we are concerned that there could be something that's fluid, but it's sitting here, if it's here, you might be able to tell because fat's bright and so is fluid. So how can you tell? But when you look at this, you've got fluid, you've got fluid. Fluid is bright, fat is dark. So anything that's bright within the fat now is going to be fluid. And that can be really useful for when you're looking for bone marrow edema, subcutaneous hematomas, subcutaneous edema, all sorts of things can be very, very bright and gives you a bit of an idea about what's going on. Even sclerosis and modic changes can be very, very useful when you're looking for pathology on this particular sequence. So my go-to sequences really are if someone said, look, you're not going to have the scanner's broken. I can only do so many things. So I'd personally say, give me this, and then give me this as well. These 3 sequences will pretty much get me most of the way to be able to answer most of the questions that come up when you're trying to do these scans. Right. So what's my take on using what? Oh yeah. So someone's asking about using grading systems for spinal canal stenosis, right? So, yeah, I know it's used, but generally speaking, I don't really use it because there's a few grading systems that people can use. So if I go say grade 1, grade 2, then what I find is that most people end up having to look that grade up, and it's just easier for me to describe, and then say what. And if I'm going to use it, then yeah, we can go ahead and use the grading, the one that's grading things. Fair enough, but I generally don't use it. I use the idea of what grading is in terms of how much epidural fat is there, how much fluid you can see, how much in the way of nerves you can see. But otherwise, I don't really bother with the gradings. Dixon protocol, yeah, really, really good, especially when it comes to focal nodular hyperplasia. Found it very, very useful over the years because I found that yeah, it can be. I mean, there's 2 options, isn't it? Either you do a follow-up in 3-6 months' time, 3 to 6 months' time, and see whether it's stable or not. But if I was a person, I'd be a bit like, well, you're telling me I've got to wait 3 or 6 months' time to know whether it's serious or not. Is there nothing you can do prior to that? And the in and out phases can be really, really useful to be able to identify whether something is focal nodule hyperplasia or not, whether there's something to worry about or not. And so, yeah, I think they're very, very useful. I don't use them all the time. A lot of the time, I don't have to bring the patient back as quick as possible. Yeah, but when we can, we try and use it. Which is the best post-contrast for lumbar studies? Because some radiology requires without suppression, fat suppression. Again, I think it depends on the person that you're talking to. I personally like to have fat suppressed contrast enhanced images. I find it difficult to really identify anatomy otherwise, but I know people have got hawk eyes, man. They think they know better and they can do it. So by all means, carry on if that works for you. Multiple sclerosis, which are the most important, and what is the appearance of multiple sclerosis? Um, you would be looking, I mean, the T2 weighted images again would be very useful. You probably want to be looking at the cord. So let's see if we can go all the way up to the cord here. I don't have the cord. So let's see if I can go up to one image here and then come up to here. You'd be looking for sort of abnormal signal intensity located within the spine, and MS has got a very specific appearance. And this is the thing: there is a bit of overlap between MRI, between neuro and MSK, and there's a proper module on how to go through it from an MSK perspective. And in fact, I do one of the talks for the lumbar spine aspect bits of the neuro radiology fellowship because they want to know the MSK side. So there's a bit of an overlap there with regards to it. But yeah, good. So I've done that one and done that one. Cool. So I don't see any other questions. Look, genuinely, I would love to see you in the community. Even join up for a bit. You don't have to do the fellowship per se. You can just join the community for a month and see what you think. There's loads of on-demand stuff on there as well from previous courses that we had, previous talks in there. Very, very useful, very interesting discussions, cases going in pretty much every week, every other day. And yeah, I genuinely, it's one of the better things, best things I've made. Have any special sequences? Well, MR myelography. Now, I have to say, I don't do those. I don't do this at all. I've never even done that. I think that's gonna be a question for someone like Ram, who's also part of this. So, yeah, I'm gonna have to defer to someone much smarter than me when it comes to myelography. Okay, cool. So yeah, the discount code, like I told you, is that one there, MSK Fellowship, is written in the chat. Please do click on the link. Just have a look at least. Join the mailing list. Just take part of the community by joining our Instagrams, YouTubes, and all the rest of it. Do loads and loads of free stuff because genuinely, we like to teach. We want to create as much difference and create as much value as possible to people. And I think obviously we do the free stuff, but there are things that we kind of end up having to. I mean, developing of something like this AI model ends up needing to get paid for and covered. So anyway, thank you so much. I think there are no more questions, so I will leave it there. Please do. I'm going to leave this. So the email, if you do want to ask any questions about a more specific, they're there. If you want to apply for group entries, we also do that. So us will sign up, and sometimes people want to join in twos and threes and things like that. So that's fine as well. So man, you want me to do the entire course on lumbaralization right now? I'm probably not going to do that right now, but there is an entire module on how to identify lumbar sacral spines and what to discuss and how to go about reporting, because that's actually very, very important so that people know what the L5 vertebra actually is when you see one. Okay. So yeah, no, you're welcome. And genuinely, yeah, please. I mean, I'm very, very happy you guys turn up to these things at least. It's wonderful to have so many people turn up and support us in any way. All right. Well, thank you so much. And I hopefully see you on the fellowship. And if not, maybe in the community. And if not, I'll probably see you around. Okay. Bye.